Good morning. My name is Judd Mao. I'm a urologist at Duke University Medical Center in Durham, North Carolina, and really delighted to have people joining us today. This is the second of our series on prostate cancer this morning. And my good friend Larry Karsh from Denver, Colorado, is going to be giving a talk on the oral oncolytics in advanced prostate cancer. We're really delighted to bring you this educational web seminar presented by LabRoots. We have a few important announcements I'd like to bring to you before we begin. The webcast is designed to be interactive, and we encourage questions. You can type in the questions in the Q&A box as Dr. Karsh is giving his talk, and then we'll do our best job possible at the end to get to as many questions as we can. You can engage the slide window by clicking on the screen icon in the lower right-hand corner of the slide window. If you have any technical problems viewing or hearing this presentation, please click on the support button at the top right of your presentation window, or submit your problem through the green Q&A button on the lower left. I'd now like to introduce today's speaker for this session, Dr. Lawrence Karsh. Dr. Karsh is a co-founder of the Urology Center of Colorado, where he serves as an attending urologist and director of research. He is a principal investigator with an experience of more than 160 clinical trials, certified principal investigator, certified by the Association of Clinical Research Professionals. Dr. Karsh has authored a number of peer-reviewed publications and serves on the editorial board for Urologist in Cancer Care and Bladder Cancer. He's active member of AUA, ASCO, SWOG, as well as Society of Urologic Oncology, serves on the Bladder Cancer Subcommittee of the SUO Clinical Trials Consortium, and is a member of the Denver Academy of Surgeons. I've gotten to know Larry quite well over the last couple of years. We served together on a course at the American Urologic Association meeting on advanced prostate cancer. He's a great presenter and really knowledgeable on this topic. So again, I'd like to now turn the podium, if you will, over to my good friend, Dr. Larry Karsh.
Thank you, Judd. So welcome this morning to this LabRoots Cancer Research and Oncology virtual conference. What I'd like to focus on are the oral oncolytics, abiraterone, and enzalutamide, and maybe answer the question which one to choose. Or maybe the more important question is, how do I sequence these, or do I even use these in combination? So these are my disclosures. You can look at that for a second there. And the topics that we're going to discuss this morning are historical review of hormone therapy. We'll look at the mechanism of action of the oral oncolytics and review the data that led to their approval, as well as the indications. And we'll briefly talk about the resistance mechanisms, as well as some clinical trials in progress and some new drugs in development. And finally, I'd like to close with a strategy for sequencing these therapies. So this is just a snapshot of our practice. We opened our doors in December of 2006. We had the mission of excellence in urology and developed the center so that we could provide all outpatient services under one roof, all GU services under one roof. We have a surgical center, we have radiation oncology, imaging, pathology, as well as a very robust research department. We have 16 urologists, a radiation oncologist, and have incorporated a medical oncologist. And we have a pathway for metastatic prostate cancer, both hormone sensitive and castration resistant. And we really believe that it's a multidisciplinary approach involving urology, medical oncology, radiation oncology. And we've developed an advanced prostate cancer tumor board that meets monthly. The doctors in the practice will send patients into that board, at which time we make decisions on how to treat these patients. And then we put them into our advanced prostate cancer clinic, which is a weekly clinic. We have 2 urologists and our medical oncologist, and we rotate those weekly visits. And we also have a bone health clinic. We have been doing this. This is how we actually started a number of years ago, by maintaining good bone health for men that go on ADT. So that it really involves using our nurses, physical therapists, and at these tumor board meetings, we actually have billing and management involved, because in order to get approval for some of these very expensive therapies, we want to make sure that we're going to be able to get the approval when we make these recommendations to the patients. So we're going to start with some questions. Now I'm going to ask you 4 questions. You don't have to give us answers at this point, but these are the same questions I'm going to ask you at the end. So I'm doing this in an effort to see whether or not I can teach you something here. And so just jot down your answer and then compare it to the one that you have at the end. But the first question is, level 1 evidence supports sequencing abiraterone before enzalutamide. True or false? The next question is, abiraterone and enzalutamide have received expanded indication for men with castration-sensitive prostate cancer prior to docetaxel. True or false? Jot down your answer. And the third question is, prednisone is administered with abiraterone to improve survival, B, prevent hypokalemia, C, decrease the mineralocorticoid production, D, prevent drug-induced hypertension, and E is B, C, and D. And the final question, enzalutamide should only be taken on an empty stomach. True or false? So modern-day hormone therapy really began over 70 years ago with a seminal paper from Charles Huggins and his team at the University of Chicago, and it was published in the Archives of Surgery in 1941. And he was able to demonstrate that reducing testosterone levels could lead to remission in patients with metastatic prostate cancer. And it wasn't until, even though that work was done in the late 1930s, he didn't really win the Nobel Prize until 1966. And a second Nobel Prize was awarded to Andrew Schally for his discovery of leuprolide. So from the 1940s until the 1980s, the mainstay of treatment for metastatic prostate cancer was surgical castration. And DES, a synthetic estrogen, was also developed in that time period. But the problem with the DES was that there were a lot of cardiovascular complications, and surgical castration really wasn't that palatable to patients. So there was really a need to develop something more palatable, and leuprolide was approved in 1985 based on the work by Andrew Schally. And so in the late 1980s, inhibiting the androgen receptor was clinically evaluated based on research that showed that androgen receptor inhibition could suppress downstream signaling and inhibit tumor cell growth. And so a class of medications was developed, the androgen receptor signaling inhibitors, flutamide, bicalutamide, and nilutamide. Now these were the first generation anti-androgens. And there were also other hormone therapies that were used. And as you can see, the response rates were not really great. They were relatively low, and there weren't any real meaningful improvements in survival or progression. And so ongoing research continues to underscore the androgen signaling pathway as a key driver of prostate growth and proliferation. And due to the continuing need for effective therapies, research is really focused on inhibition of the androgen receptor signaling pathway. So as you can see here, the first step in that pathway is binding of androgen to the receptor in the cytoplasm. The receptor translocates into the nucleus, and that's where DNA transcription takes place so that you get tumor growth and proliferation. And the disease progression, despite medical or surgical castration, signals the emergence of a prostate cancer phenotype that can survive and proliferate in a low androgen environment. And historically, that's been referred to as hormone refractory or hormone or androgen independent prostate cancer. But among the most significant advances in prostate cancer over the past decade has been the realization that these tumors are not in fact hormone refractory, but hormone ultrasensitive. And several mechanisms have been identified that account for the ability of prostate cancer to progress despite castration. And that is that we know that the adrenal produces androgen, and even the tumor itself produces androgen. And although we kind of credit that knowledge to the past decade, it was really Jack Geller back in the late 1960s who found that prostate cancer tumor cells had high levels of testosterone. And also these resistance mechanisms include alterations of the androgen receptor, so that in response to low androgen, you get overamplification or overexpression of the androgen receptor. There are mutations that develop so that these receptors will respond not only to androgen ligands, but to progesterone, estrogen, and even some of the first generation anti-androgens like bicalutamide. And then there's the ligand-independent splice variant, and we'll talk about that a little later, but this doesn't even need a ligand to signal the receptor. And so the androgens are produced at 3 sites, but we're going to talk about the definition of castration-resistant prostate cancer for a minute. So we have it categorized into M0 and M1. And what this requires in castration-resistant prostate cancer is that the testosterone levels are less than 50. Well, why 50? Well, because when they first started measuring testosterone, we didn't have the technology to measure below. But we now know that we want it less than 50 and probably even less than 20 to approach castrate levels. And we do have the technology now to even measure almost down to 0. So the M0 categorization is PSA progression only, and the M1 is radiographic progression. So there's an objective response that we can see radiographically. So the importance of distinguishing between these two is really because these new drugs that we're talking about, these new oncolytics that have been developed since 2010, really are approved only in the M1 space. There are no drugs to date approved in the M0 space. There have been a number of trials and therapies that attempted it but failed. There was the endothelin antagonists, zibotentan and atrasentan. They didn't demonstrate significant clinical endpoints, and so they have been withdrawn. There's only one drug that really has been shown to delay bone mets, and that is denosumab 120 milligrams, which is marketed as Xgeva. So it did demonstrate a median 4-month delay in progression of bone mets, but it was not approved for that indication. It's been approved for prevention of skeletal-related events. So that's the importance of knowing the categorization. And clinical drug development for castration-resistant prostate cancer has really entered a renaissance era. There have been more new therapies approved since 2010 than in the prior 3 decades. I'm just going to go through a brief timeline for you. In 2010, the first drug to be approved on, and these 5 out of these 6 drugs were approved on overall survival endpoints. And the first drug to be approved was Sipuleucel T, which is marketed as Provenge. That was approved in April of 2010 based on a 4-month median overall survival advantage. Cabazitaxel, which was a second-line chemotherapy in patients who failed docetaxel, also on overall survival, was approved in June 2010. And then we had the first-in-class human monoclonal antibody against Rank-Ligand, which was denosumab, 120 milligrams, which is Xgeva, and that was approved to delay skeletal-related events, and that was compared to the gold standard at the time, zoledronic acid, and it was a head-to-head comparison, and it was shown to be superior. And then in December of 2011, the first indication for abiraterone in the post-chemo space was approved. And in August of 2012, the first indication for enzalutamide, and that was approved in the post-chemo space based on overall survival and progression-free survival endpoints. And then we had the expanded indication for abiraterone in December of 2012 in the pre-chemo space, and then in May of 2013 we had the first alpha emitter, radium-223, which was approved also on overall survival in symptomatic patients with bone metastases. And then the expanded approval for enzalutamide in the pre-chemo space occurred in September of 2014. And so it continues. In 2015, we have in development 2 androgen receptor antagonists, J&J 560-21927, which was formerly ARN-509, and ODM-201. Those are both drugs that work like enzalutamide. And then we have a novel therapy called galeterone, which actually is a combination of an androgen receptor antagonist and a biosynthesis inhibitor, and we'll talk about that a little later in the lecture. So these are the 2 currently approved androgen signaling targeted agents, abiraterone and enzalutamide, and I discussed the timeline on their approvals in the pre and post chemo space. So abiraterone is an inhibitor of CYP17 or 17 lyase, and what it does, this is the mechanism of action, it blocks the production of androgen in the adrenal gland as well as in the prostate cancer tumor itself, and it can block androgen wherever it's produced, even in the testicles, but it's really not designed to be a monotherapy, so that you really need to continue using GnRH analogs or surgical castration for the testosterone that's produced in the testes. And this is, the CYP17 complex is required for biosynthesis, and abiraterone blocks the pathway at 17 lyase so that you suppress downstream signaling of testosterone and DHT that work on the androgen receptor. And the steroidogenesis pathway includes biosynthesis of androgens, cortisol, and mineralocorticoids. So we have our sex, sugar, and salts, and ACTH is the in the pituitary drives the pathway, and it's under negative feedback control of cortisol. So that when you inhibit 17 lyase with abiraterone, what happens is the pathway downstream for cortisol gets suppressed, and when you suppress the cortisol, then you actually increase ACTH production in the pituitary, and the pathway to the mineralocorticoids is open. It hasn't been blocked by the abiraterone, so that you can get an increased mineralocorticoid effect when you give abiraterone. And the reason for having to use prednisone is to make up for the cortisol which is lost. So they're not really getting a high prednisone dose. It's really a physiologic dose of about 5 to 10 milligrams a day. It's actually 10 milligrams in the for the drug. But when you co-administer that, you reduce the ACTH drive, and you will suppress that corticoid, the mineralocorticoid effect, which can cause some adverse reactions. So abiraterone was first approved in the Cougar 301 trial. This was an international double-blind placebo-controlled study involving 1,195 patients who were castrate metastatic, castrate resistant, and they had already received chemotherapy. They were randomized in a 2-to-1 fashion to get abiraterone plus prednisone, 5 milligrams twice daily, or placebo and prednisone. And the primary endpoint was overall survival. Trial was initiated in May of 2008 and completed in July of 2009. Now, the baseline characteristics were balanced between the both groups. The average median age was about 69, and these patients had a pretty heavy burden of disease. About 90% of them had bone metastases, almost half of them had soft tissue or node metastases, and about 20% of them had liver or lung metastases. And the primary endpoint is shown on this Kaplan-Meier curve. You can see that it separates pretty nicely at about 3 months. And it had a hazard ratio of 0.71, which was statistically significant. And the median overall survival was 4.6 months. And so that abiraterone was first approved based on this trial. Now we have the Cougar 302 trial. This is in the chemo-naive patient. Again, it was a international multi-center study, double-blind, placebo-controlled, and it involved 1,088 subjects who were asymptomatic or mildly symptomatic, and they were randomized in a 1-to-1 fashion, again, to get abiraterone and prednisone or placebo and prednisone. And keep in mind, when we talk about metastatic castration-resistant prostate cancer, these patients all had to remain on their GnRH analog or have been surgically castrated. But the co-primary endpoints were radiographic progression-free survival and overall survival, and some of the secondary endpoints were time to opiate use and time to initiation of chemotherapy. And the baseline characteristics were balanced. In this group, the median PSA was around 40 in each group, and these patients had a pretty heavy burden of disease. You can see that about half of these patients had more than 10 bone lesions, and about half had soft tissue or no disease. Now, the interesting thing about this trial is that they did not allow visceral mets in this trial, and these patients had to have they're minimally symptomatic, so that their pain scores, you can see that they were 0 to 3 on a scale of 10. And so this was one of the co-primary endpoints, radiographic progression-free survival, hazard ratio 0.52, highly significant. And you can see the separation that occurred even about 2 months. And so these patients had a 8.3 month advantage in developing progression if they were on abiraterone. And that's important because if you can delay progression, you delay all the morbidity and even death in patients. And then the the overall survival was also statistically significant. In the first analysis that was pre-specified it was the first third analysis, the overall survival showed a tendency to improvement, but it wasn't statistically significant. And in a pre-specified final analysis with a median follow-up of 49.2 months, it became statistically significant, and there was a 4.4 survival advantage. And so these are some of the AEs of special interest in abiraterone. We have a higher incidence of hypertension, hypokalemia, and fluid retention in patients on abiraterone, and this really relates to the mineralocorticoid effect. And then there were LFT abnormalities, which were higher in the abiraterone group, and this drug is metabolized in the liver, like many drugs that we take. But there were none of these patients died of hepatotoxicity, and these were really lab abnormalities, and they're pretty reversible. And even in my own clinical practice, I see that when I do have an issue, which is rare, they do respond pretty rapidly after you stop the drug. So, in conclusion, abiraterone received the post and the pre-chemo indications in 2011 and 2012 based on those endpoints that I described. The dosing is 1,000 milligrams a day. There are 4 250 milligram tabs that are taken on an empty stomach with 5 milligrams of prednisone BID. The prednisone needs to be taken with food, otherwise patients get some gastric upset. But if you have food in your stomach, the absorption and concentration in plasma it goes up dramatically, so that they have to be on an empty stomach. And what we do is monitor for hypertension, hypokalemia, and fluid retention due to the mineralocorticoid excess. And LFTs are monitored. The label wants you to look at LFTs every 2 weeks for the first 3 months and then monthly thereafter. So now let's look at enzalutamide, an antiandrogen with a high selectivity for the receptor. And in the preclinical models, there was no agonist activity seen in enzalutamide as it was with other antiandrogens. So this is how enzalutamide works. Just like bicalutamide, flutamide, nilutamide, and the other first-generation antiandrogens, it binds the receptor in the cytoplasm. But unlike those older drugs, it has 3 mechanisms of action, so that it not only binds the receptor in the cytoplasm, it inhibits the translocation into the nucleus, and once it's in the nucleus, you don't have transcription with DNA. So this leads to cell death, reduced tumor volume, and decreased proliferation. So it was more potent than the first-generation antiandrogens, and it was developed in the laboratory in bicalutamide resistant cells. So enzalutamide worked when bicalutamide stopped working. And this was the AFFIRM trial and the post-chemotherapy. Got the first indication for enzalutamide. 1,199 subjects were randomized in a 2-to-1 fashion to get MDB-3100, which was the name of enzalutamide when it was in development. They got either the enzalutamide or placebo. Primary endpoint was overall survival. Secondary endpoints were radiographic progression-free survival, PSA response, time to PSA progression, and quality of life indicators. And the treatment arms were balanced, pretty balanced between both arms. You can see that these patients had a high burden of disease in bone, about 90%, and also in viscera or soft tissue, about 29%. And and another interesting point about this was that 84% of these patients had received prior bicalutamide. So this was the primary endpoint illustrated on this Kaplan-Meier curve. You get a separation at about 3 months with a hazard ratio of 0.63, which was statistically significant. And this led to a 39% reduction in the risk of death anywhere along this curve, which equated to about a 4.8-month survival advantage. Now, when we look at the radiographic progression-free survival, this was also statistically significant with a 60% reduction in the risk of radiographic progression, hazard ratio 0.40. So there was about a 5-month delay in progression with enzalutamide. And this was the PREVAIL trial. This is in the pre-chemo patient group. 1,717 patients were randomized in a 1-to-1 fashion to receive enzalutamide or placebo. It had co-primary endpoints, overall survival and radiographic progression-free survival. And some of the secondary endpoints were time to first SRE, initiation of cytotoxic chemotherapy, soft tissue response, PSA response rate greater than 50, and time to PSA progression. And it hit all of these endpoints. And some of the baseline characteristics, the median age was 72. PSA was about 50 in each group. And these patients had, over 80% had bone mets, about 60% had soft tissue or nodal mets, and visceral metastases was allowed in this trial, whereas in the abiraterone trial, visceral metastases were not in the pre-chemo trials. And so it was about 11-12%. These patients had lung or liver or both. And so in the PREVAIL trial, the overall survival was statistically significant with a hazard ratio of 0.71, and there was a 29% reduction in the risk of death, and the now that was in the first interim analysis, but there was an updated overall survival analysis because initially it was about a 2-month difference, but when they did the overall survival in the extended analysis, there was about a 4-month difference in overall survival. And when we looked at radiographic progression-free survival, again, statistically significant with a hazard ratio of 0.17 and an 83% reduction in the risk of radiographic progression. So in the first analysis at 12 months, 63% of the patients on enzalutamide were progression-free, whereas only 8% of the placebo group was progression-free. And when we looked at some other endpoints, the time to chemotherapy, there was about an 18-month difference, so that patients who were on enzalutamide did not require chemotherapy for 18 months. And that's important because if you can delay the effects of chemotherapy, that can be very beneficial to the patients. And there was a 28% reduction in the first skeletal related event. Skeletal related events, remember, are fracture, surgery to bone, radiation to bone, usually because of pain, and spinal cord compression. So that's really the definition of skeletal related events. But if you can prevent fracture in these patients, remember that there's about a 30% mortality in older patients who get a hip fracture. So some of the adverse events of interest, seizure risk, something you need to pay attention to. Even though it was low, it's something that did occur. And in the AFFIRM trial, 7 of 800 patients, or 0.9% in the enzalutamide group, experienced a seizure. No patients in the placebo group experienced a seizure. In the PREVAIL trial, the pre-chemo trial, it was 1 in each of the groups that experienced a seizure. And when they went back and looked at the AFFIRM trial, in those 7 patients, 2 of them actually had brain mets. Another patient was given an inadvertent dose of IV lidocaine. Another patient had cerebral atrophy. He had a history of alcohol abuse and was originally started on Haldol. And then there was another patient who may have had a syncopal episode, but they thought that the description was more like a seizure. So even though those numbers are low, it's something you need to pay attention to. And some of the other adverse events of interest with enzalutamide are fatigue, diarrhea, hot flush, and hypertension. And so you can see when we talk about grade 1 through 4, there's a difference between enzalutamide placebo. But when we get into the grade 3 and 4, the more severe adverse reactions, you can see that they're much lower, but there's still a little difference. And one thing that sticks out here is the hypertension, grade 3 and 4 in the PREVAIL trial in that right lower bottom. Now, we're not really sure what the mechanism of action is for hypertension with enzalutamide, but we do know that in the PREVAIL trial, about 60% of patients going into that trial had comorbidity of hypertension. And so, in conclusion, these are the indications. 2012 and 2014 is when it received its approval based on these endpoints in the trials. The dosing is 160 milligrams per day. They're 40 milligram caps, so you take 4 of them at once. There are no food restrictions and no requirement for steroid co-administration. And the adverse events of interest, we mentioned the seizure and monitoring patients for blood pressure issues. And, just like all drugs, we can have reactions in the cytochrome 450 system. And with enzalutamide, if patients are on warfarin, you probably want to conduct additional INR monitoring because the serum concentration is reduced when you give enzalutamide. But these patients are being monitored pretty frequently anyway. So when we compare abiraterone to enzalutamide, They have different mechanisms of action. Abiraterone is an androgen biosynthesis inhibitor. Enzalutamide is an androgen receptor antagonist. They're both effective before and after chemotherapy, and the endpoints were overall survival and progression-free survival, so they have improvements in both of those endpoints. And some of the potential adverse effects we talked about, but in abiraterone, hypertension, hypokalemia, and LFT abnormalities. In enzalutamide, seizures, hypertension, and fatigue. Abiraterone needs to be taken on an empty stomach. Enzalutamide does not have any food requirements. Abiraterone requires prednisone, enzalutamide does not. And when it comes to cost, there is a cost advantage favoring abiraterone. So I don't know how many of you believe in guidelines or even look at guidelines, but these are guidelines from the AUA, and there are 5 index patients, but I'm showing you index 2, and this is in the pre-chemo space, but you can see that abiraterone and prednisone have class A recommendations, which is their highest recommendation. And so that's the AUA guidelines, and I would really encourage you to look at that because it takes you step by step through all the other therapies that are approved. And the NCCN guidelines also give enzalutamide and abiraterone category, or 1, which is the highest category, recommendation. And I would encourage you to use these guidelines, and it really helps us also with our payers, because when we can show that these are guideline-approved therapies, we rarely get a rejection for use of that drug. So now we're going to shift gears a little bit and talk about AR resistance mechanisms. So there are a number of different resistance mechanisms that develop in castration-resistant prostate cancer, and ARV7 has been identified, and it seems to be the most abundant right now in CRPC, but keep in mind that others exist. Now, this was an important paper by Anton Arakis and his team at Johns Hopkins, and this was published in the New England Journal in September of 2014. And what they did was they looked at, they had 31 patients in each arm, and these patients were going to get abiraterone or enzalutamide. And what they looked at was the ARV splice variant. And when you have this, when you express this variant, you have a resistance to enzalutamide and abiraterone. And ARV7 is a splice variant that is a truncated form of the antigen receptor, meaning it's a shortened form of the antigen receptor that lacks the ligand binding domain, or the C-terminal. And this is the target of testosterone binding to that receptor. And so, in essence, it's the target of enzalutamide and abiraterone. But it does not require testosterone to be stimulated, so it's constitutively active as a transcription factor. So it does not require, so it signals without engaging a ligand. So that's kind of a scary thought, but that's something that we've found in the recent years of research. And detection of ARV7 is usually in circulating tumor cells, and not only do these patients not respond to the enzalutamide or abiraterone, but they do poorly. Their overall survival and progression is inferior to patients that don't have the ARV7 splice variant. And so this is just kind of a little cartoon depicting, you have the full-length androgen receptor, and you can see that the C-terminal is the ligand binding domain, so testosterone binds to that, and abiraterone and enzalutamide require that functional ligand binding domain in order to be effective. So that with the splice variant, during the translation process, this C-terminal gets terminated. So it's there's a stop code that develops, and you don't get that C-terminal that develops. And so that abiraterone and enzalutamide will lose their effect, and this thing will be off on its own, growing and stimulating tumor growth without even needing testosterone. So these are the 3 different assays that are available. There's a Hopkins, the Adnagen, which is an immunogenic assay. And this is one that's actually out there, but it's not commercially available. It's being used in clinical trials, and we are actually working with it right now. We just opened the Tokai 001 trial, which I'll talk about, and we're using this assay to measure ARV7. But Memorial Sloan Kettering has an immunofluorescent assay in development, and MD Anderson developed one that was from bone marrow biopsies looking at antibodies to ARV7. So that's not going to be as practical as doing a blood draw. But these are the upcoming assays that are going to be available. They're not commercially available yet, but hopefully in the next year or two. So when we looked at the Antonorakis study, we found that of the 18 patients, out of those 62 patients, 18 patients had the ARV splice variant, and 0 had a response, so that they didn't get a PSA of greater than 50% reduction, and the overall survival and radiographic progression-free survival were inferior. These patients progressed much more rapidly than patients that did not demonstrate that variant. And so if you look over here in that left-hand box, this is actually when we talk about the prevalence of ARV7. These are some combined studies, but before the ARV7 has been measured before patients get enzalutamide or abiraterone, and it's about 12%. If you look at the Antonorakis study, it almost approaches 20% had it. So when you look at this developing after patients get enzalutamide or abiraterone, 25% of patients in the post-enzalutamide treatment developed the ARV7 splice variant, 51% in the post-ABI, and when you combined ABI and enzalutamide, 67% expressed the variant. So in conclusion, detection of the ARV7 in circulating tumor cells is associated with resistance to enzalutamide and ABI, and the ARV7 actually may be used as a biomarker. I think that it may make an excellent biomarker to predict resistance, and so you'll know whether or not to use it for enzalutamide, and whether or not to use enzalutamide or abiraterone based on whether or not the patient already has an ARV7 variant. And it may provide a target to fuel the development of new therapies that target the ARN terminal domain. So some of the new drugs in development for 2015, going back to the NCCN guidelines, this was 2015 version. The NCCN believes that the best management for any cancer patient is in a clinical trial. Participation in clinical trials is especially encouraged. And really, if it weren't for these clinical trials, we wouldn't have the development of the drugs that we have. So this is ARN-509. This is the mechanism of action. It's a androgen receptor antagonist. It works like enzalutamide, so that you have those three mechanisms that blocks AR signaling, impairs the nuclear translocation, and the DNA binding. And this is a trial. This is an M0 trial. It's called the Spartan trial. It has it opened in October of 2013, and what it is comparing is it's looking at patients who are at high risk for developing metastases. And so it's looking at men that have high PSA, short doubling times, but no metastases, and they are castrate resistant. Their progression on PSA only M0. And so these are being randomized in a 2-to-1 fashion to get ARN-509, 240 milligrams versus placebo. And so that is a trial in progress, and we'll see, we talked about all these drugs being approved in the M1 space. Hopefully we're going to have these drugs moved up into indications in the M0 space, which is a real unmet need. ODM-201 is another androgen receptor antagonist in development, and the Aramis trial, phase 3, that they're looking to enroll 1,500 patients, M0, castration-resistant prostate cancer. It's currently enrolled. The primary endpoint is metastasis-free survival. Secondary endpoints, overall survival, time to first SRE, time to initiation of chemotherapy, and time to pain progression. And that opened in January of 2015, and so it's currently enrolling. And now, this is a novel agent, galeterone, TOK 001. It's a first-in-class 3-in-1 molecule. It's a pill. It purports to have CYP17 inhibition, androgen receptor antagonist qualities, as well as being an androgen receptor degrader. So they may work on that variant. So that it just completed a phase 2 trial, and we just opened the phase 3 this last week. We were waiting actually on the ARB7, the androgen assay, to become available, and it was just happened. So this is the mechanism of action of galeterone. It's a small molecule. It has 17 lyase inhibition qualities like abiraterone, AR antagonists like enzalutamide, but what also differs with this is an AR degrader. So it has all three of these mechanisms. So if it ends up to show the endpoints and purports what it proves to be what it purports to be, this is going to be a super drug. But as we know in clinical trials, sometimes phase 2 doesn't translate into phase 3, and so we have to wait for the results. But the nice thing about galeterone is that you don't have to administer steroids. The fasting is not required. They don't believe that it has any seizure risk because it is not a GABA1 antagonist, and it may be active in this C-terminal loss of the ARB7 splice variant. So this is the schematic of the trial. We're going to include M1 patients who have progressed, and they're going to randomize. And the other interesting thing about this is, in order to get into trial in screening, you have to have a detectable ARB7 in your circulating tumor cells. So that, remember, in the studies that I showed you, there's a pretty low rate of having ARB7 before you use any treatments. So there's going to be a high screen fail rate for this. And they're going to randomize 170 patients in 1-to-1 to get galeterone or enzalutamide. Primary endpoint is radiographic progression-free survival. Secondary endpoints are overall survival, skeletal-related events, and time to cytotoxic therapy. They're also going to be looking at biomarkers and quality of life indicators. So what is the rationale for combination therapy? By co-targeting the androgen receptor and androgen biosynthesis, it may result in a more potent androgen signaling inhibition than either approach alone. So maybe we can avoid the escape mechanisms. And in the combination trials, we have the Alliance Phase 3 trial and the J&J PCR 3001. This is the Alliance trial. It's a intergroup trial, and it's looking at chemo-naive M1 castration-resistant prostate cancer patients. They are being randomized to get enzalutamide or enzalutamide plus abiraterone. Primary endpoint is overall survival. Secondary endpoints are progression-free survival, as well as radiographic progression-free survival. They're going to even look at using sodium fluoride PET scans to measure tumor burden. So this is in progress, and it opened in May of 2014. So hopefully we'll get some answers on combination therapy. And this is the J&J PCR 3001 trial, which opened in December of 2014. This is also looking at combination. They're looking to enroll about 960 patients. Metastatic castration-resistant prostate cancer patients will be randomized in a 1-to-1 fashion to get abiraterone plus or minus ARN-509, which, remember, is another androgen receptor antagonist in development right now. And the primary endpoint is going to be radiographic progression-free survival. Secondary endpoints are time to pain progression, time to opiate use, and time to chemotherapy. So as far as sequencing, until level 1 evidence and biomarkers are available, the FDA indications and the AUA and NCCN guidelines will really dictate how we sequence these targeted agents. And really, it's going to come down to your own personal experience with these drugs and how you feel comfortable in sequencing them. But, you know, there's still a number of answers that need to be, questions that need to be answered, and hopefully we'll have those in the next few years. But this is the disease continuum. This is the playing field. You can see the red arrows. These are the approved therapies that have been approved based on overall survival since 2010. In the pre-chemo space, we have abiraterone, enzalutamide, CYP-T, and radium-223. And in the post-chemo setting, enzalutamide, abiraterone, cabazitaxel, which is a second-line chemotherapy, as well as radium-223. So how do we sequence it? Well, this is my strategy for sequencing in 2015. So that first thing that we do is when patients come in that are being treated on androgen deprivation therapy, we put them in our bone health clinic. We do a DEXA scan, look at vitamin D levels, calcium, and if they are osteoporotic, we want to prevent fractures to bone, and you can use the oral or IV bisphosphonates or denosumab 60. 60 milligrams is marketed as Prolia. Really, between those choices, that really was the only one to offer level 1 evidence of fracture prevention, and that was in the HALT trial. And then if the patients develop bone metastases, then if it's significant, we start them on either zoledronic acid, marketed as Zometa, or denosumab 120, which is Xgeva. So that's to prevent skeletal related events. So that's how we first start in treating these patients. And then I believe that the initial platform should be immunotherapy. Now I don't know if CYP-T or Provenge is the ultimate answer. It certainly was the first immunotherapy to show a survival advantage in adult solid tumor, and that was in prostate cancer. And I do believe that the immunotherapy should be started early in patients that are minimally symptomatic with the low disease burden so that you can get a more effective immune system response. And so whether or not you believe in immunotherapy as your first choice, the next would be abiraterone or enzalutamide. And so I like to start with the simple things first, going with the oral oncolytics. And when it comes to abiraterone and enzalutamide, you know, I showed you the data. They're both very effective drugs. And so the way that I would distinguish on who to use abiraterone or enzalutamide is if the patient has significant hypertension, if they have diabetes, whether on insulin or the oral hypoglycemics, or even congestive heart failure, those are patients that I will probably start on enzalutamide. And if a patient has a seizure disorder, then I will start the patient on abiraterone. But I think it's going to depend on your comfort level. Remember, even though abiraterone requires, you know, the food requirement, it requires that they have to have an empty stomach, that they have to take prednisone, and you have to do monitoring of LFTs. At first blush, it looks like it's a very difficult drug to administer, but it really isn't. You'll find that if you start using it, it's pretty simple. Enzalutamide, of course, is just like giving our first-generation anti-androgens, so it's simple to administer. And so I think that you need to get a comfort level with both of these if you're going to start treating patients with castration-resistant prostate cancer. And then after that, I'd move on to radium-223 if the patients have symptomatic bone mets. Again, if these patients develop visceral mets, you kind of lose that window to use radium-223. And radium-223 is being used, I know, in combination with things like abiraterone, because it's a 6-month administration, and so these patients do progress, their PSAs don't really change, and so patients probably need other therapy in the meantime. And then there is a role for chemotherapy. Even though we're putting it off, chemotherapy can be very effective, and when given in the hands of a reasonable oncologist, can be very efficacious. And so we start with docetaxel. If patients fail, then go on to do the second-line cabazitaxel. And there is a trial right now for Astana comparing docetaxel and cabazitaxel head-to-head. and we're going to have to see what that shows us to tell whether or not we should be using cabazitaxel up front. So that's my strategy for sequencing. And we're going to go back to these ARS questions. Now is the real test. So that level 1 evidence supports sequencing abiraterone before enzalutamide. True or false? So we're going to see what your answers are here. And I want you to compare this to what you answered before to see whether or not I've taught you anything during this lecture. Okay, do we have the answer? Okay. I guess we should have some music that we can play while you're answering these. Okay, so half of you got it right, and half of you got it incorrect. So it is false. It doesn't. We don't have level 1 evidence yet to say that you have to use abiraterone before enzalutamide. Okay, let's go on to our next question. Remember, that was a sequencing question, and we really don't have evidence to show that abiraterone is better before enzalutamide. So we'll go on to our next question. So abiraterone and enzalutamide have received expanded indication for men with castration-sensitive prostate cancer. True or false? Okay, so let's see here. We're getting all of our answers in. And so you all said true. Well, I guess I stumped you on that one. It's actually in castration-resistant prostate cancer prior to docetaxel. Remember, all these drugs are approved in the castration-resistant setting. So that was just a little, I guess it was a trick question. So let's go on to the next question. Enzalutamide should only be taken on an empty stomach. True or false? I would sing to you, but you'd probably all leave the conference here. Yes. And so the answer, well, that was question 4, okay. The answer is correct. Prednisone is administered with abiraterone to also to prevent hypokalemia, decrease mineralocorticoid production, and prevent drug-induced hypertension. All 3 of those mineralocorticoid effects. So it looks like the majority of you have answered that adequately. I think we missed the question on enzalutamide should be taken only on an empty stomach. Can we just go back to that real quick? Correct. The answer is false. It can be taken with or without food. So not only on an empty stomach. Okay, well, very good. I hope that you've learned something from this lecture, and I think that we will probably open it up to some questions if we have some time.
So, Larry, this is Judd Mal. I really want to thank you for a great presentation. I mean, an amazing overview of advanced prostate cancer. We have about a minute left. One quick question that came in from our, we had a great audience. One question that came in regarding Provenge and the quartile data. Do you think that, are you kind of a believer that Provenge should be sequenced in for men with a low PSA?
Yes, now that was a post hoc analysis, and I think you were involved in that, Judd. But yeah, I think that patients with low PSA, you remember in that quartile data, 22, if you got a PSA of under 22, those patients actually had about a 13-month median survival advantage. So I do believe that it should be used early, lower PSA, and that usually indicates less tumor volume or tumor burden. And so I think those patients do better. And so the earlier, the better. I get that on board first, and then move on to my other therapies.
Great. Well, great. Well, I think we're almost out of time. Again, I'd like to thank Dr. Larry Karsh very much. It was an excellent presentation. I want to thank the audience for their interesting questions and participation today. And I want to also mention that today's webcast will be available for on-demand viewing through March of 2016. You will receive an email from LabRoots alerting you to when this webcast will be available for replay. We invite you to forward that announcement to your colleagues who may have missed today's live event. So again, on behalf of LabRoots and Dr. Karsh, I'd like to thank you very much. We'll see you next time. Enjoy the rest of today's programs.